Greetings. I'm Jennifer Kennedy, the lead for quality and compliance at CHAP, and welcome to this episode of CHAPcast. So today I'm joined by my friend and colleague and partner in crime, Kim Skian, and what we're going to do today is attack the calendar year 2027 proposed home health rule. And we're going to dive into this anticipated update for calendar year 2027. And while payment is a piece of this rule, we're not going to really spend a lot of time on payment. But this year's rule, a proposed rule rather, goes far beyond reimbursement rates. It does signal a continued focus on things like value and quality measurement and transparency and program integrity, all while home health providers have to deal with challenges like workforce shortages and rising costs for operations and increasing demand for care in the home. So welcome, Kim. You ready to talk some proposed rule?
Sure, Jennifer. As always, we know that CMS keeps coming with the proposed rules and final rules and memos, so there's never a dull moment, especially in our world and your world, in compliance and quality and regulatory oversight. As you said, we focus on accreditation, but just there were actually a couple of good news items in the proposed rule, assuming that they're finalized. One, from a payment perspective, was an increase in estimated 2.4% of a payment, plus continuing the temporary PDGM adjustment, and also no proposed changes to the VBP model. But there are proposals impacting home health quality reporting program, including but not limited to OASIS and HHCAHPS submission timelines. And there are some requests for information for agencies to review and consider providing comments. And I think that, that's going to be something I know that, we'll both be commenting on, in the couple of areas that we feel are really areas to highlight. As you said, they're also proposing significant program integrity and provider enrollment changes and additional fraud prevention measures affecting both home health agencies but other providers. And it is in those proposals that we want to really spend time on, at least, I do, because providers really need to be aware of the potential impact, for all providers. So,
well, Kim, let's unpack some of this and hit those highlight areas outside of payment. I mean, I'm happy that there is a proposed bump to the payment. We'll see if that sticks to a final rule. But let's go ahead and unpack some of the other items that I think are really important for our partners to understand about this rule.
Yeah. Absolutely. So I think you and we're both passionate about a couple of these proposals. And for me, it's provider enrollment. And I know for you, palliative care.
Yes.
And so I'll, go over the key points or concerns about provider enrollment that agencies need to be aware of. These are sweeping enrollment and compliance changes that affect all Medicare providers and suppliers, and that includes home health and hospice and DME, again, unless it's explicitly excluded. But the key proposals that providers need to hear: there are expanded grounds for enrollment denials for up to 10 years for pretty much any reason, including like a clerical error. So up until at this point, a provider enrollment or A55A application will be potentially denied if there is a suspicious documentation, ownership issues, concerns about fraud, or abuse in the system or a track record. This proposed rule is basically widening the scope to deny on anything. So if there's a clerical error, a dash is missing or a suite number is wrong, you could be denied and then subsequently disenroll or denied for 10 years. The other couple is just, we know that the CHOWs, change of ownership, there are restrictions on change of ownership within 36 months. We know this, it's been in place for a long time. But failure to comply with the 36-month rule in terms of not notifying CMS, or, and this is the key part that I think is important, there are providers that are failing to, that are circumventing the requirement under the guise of a management agreement. So for organizations that enter into, or they're in advance of a CHOW, traditionally they utilize a management agreement from the seller to the buyer to be able to have that transition. So in this particular case, should this become finalized, counsel, organizations are really going to have to look at this, from their counsel, with counsel.
Was that like a workaround that organizations did in order to keep the process moving forward?
So the language in the proposed rule talks about circumventing the requirement under the guise. This is CMS speak, alluding to the fact that that's what the reason is for. I would like to think that not all providers are trying to circumvent, but that they may not realize that a management agreement, would not be applicable in this case. But the point is that it's, again, has more broad effects for organizations to really think through how this may impact them, especially with the moratorium, and what would trigger a CHOW. The other is the expanded definition of managing employee. That includes all medical directors, not just nursing home and hospice, clinical directors, department heads, supervising physicians, alternate administrators, and all other clinical personnel. And that it doesn't matter if it's a W-2 or a contracted employee. So looking really at the broad scope and the implication is really important. There's also some physics. Yeah.
I'm going to ask you this question. Were we at all surprised to see this program integrity proposed language baked into this rule, given that we are in a home health moratorium?
So I can say, we were not, and when I say we at CHAP, but I'm also on the National Alliance for Care at Home, Home Health, Program Integrity Work Group. And right. I would say that we all anticipated some level of program integrity because we know look at what's been coming out, really since the beginning of this year, and even, since the beginning of the administration, but really in 2026. What I think is what was not expected, I think, was the breadth of these proposals. There are some concerns at the national level about the legality of some of the broad strokes, if you will, the broad brush that this is being painted. That's not for us, to look at, but certainly organizations that really need to take a look at these proposals, listen and talk with their state associations and national association to be able to participate in providing feedback. The only other, there's others, there's, expanding signage requirements, et cetera. But the two that I do want to point out for that also impact providers, because home health agencies will say, I'm not doing anything wrong, so I don't have to worry about it. It's the bad guy down the street, who's having a problem. Well, they did put two new proposals in this proposed rule. One is guilt by proximity, the same suite, where they can deny an enrollment or of even a compliant provider because the provider's practice location is in the same suite or office as a different provider whose enrollment was revoked or denied. And the same for your zip code. So it's not just the building, not just the suite. It's, revoke for your zip code. Excess providers in the area. So CMS may revoke an enrolled compliant provider because it's located in a geographic area that CMS determines has an excessive number of providers and suppliers. Now, there's no definitions in these. In the proposed rule, and CMS notes that they will, in the final rule, provide the definitions in plain language. That's not sufficient. We don't know what that means, right? And what those potential limits are. Yeah. But this is where agencies have to understand. It's not just about, I'm going to say, like what you consider to be the bad guy or the other guy. It's impacting or potentially impacting everyone. That's the scary part.
Extremely concerning, that particular item there. It's very concerning because you could be one of those, high road compliant organizations and you're going to get punished if this goes through.
Yeah, absolutely. So Jennifer, that's a sort of a high level synopsis of, my passion project right now, my passion point. I'm about, why don't we turn to yours? Although it really is both of ours, but you are, this is your focus, and rightfully so.
Yeah, so there was an RFI, request for information, in the rule, and this was weird the way that the language was couched, because while CMS was asking for feedback, it was asking for feedback on how to implement palliative care through the home health benefit. And I'm talking about community-based palliative care. So they weren't really asking, hey, do you think it's a good idea if we run palliative care through home health? They were more saying, the way that we laid it out in this proposed rule, do you have any other feedback for us given that layout? So to me, Kim, that signals that CMS has made that decision that they're going to try to run community-based palliative care through the home health benefit. And they talked a lot about how the home health benefit has the components to support community-based palliative care. For instance, it has skilled clinicians, nursing, therapists, social worker, etc. And also they stated that it is their belief that palliative care is provided across the entire Medicare continuum. So they didn't, they're not entertaining, rather, that palliative care is connected to the hospice care benefit or even to end of life. They're really looking at palliative care as something that can happen to a seriously ill individual across that Medicare continuum. And there's different pockets in the continuum that would help support that journey. And then when they do get to that 6-month or less prognosis, then they would obviously elect their Medicare hospice benefit if they choose to. So they're looking for feedback on expanding access to community-based palliative care, and considering longer-term policy options as well. So just to reiterate, they are not, based on the reading I've done and the hospice rule, the proposed calendar year physician fee schedule, where they're asking about feedback for community-based palliative care outside of the hospice benefit. They're not planning to make a palliative care benefit standalone with a payment stream. So I'd love to hear your thoughts on that. I have concerns here because I don't know if a palliative care patient is going to fit into the box of a Medicare Medicare home health benefit patient.
Right.
For example, the palliative patient would have to meet all the criteria of home
eligibility,
health, i.e. homebound, right?
Yeah. Mm-hmm.
So there wasn't any discussion of like carve out or anything like that. So I'd love to hear what your thoughts are about this.
Well, that was my concern also when I first read it. I do remember, and maybe it was the physician fee schedule. You know better than me, but one of the proposed rules, they had more specificity around what the components of a palliative care program would look like. And again, that's not all apples to apples, but it had more definition. But in this case, carving it or including the palliative care benefit into home health, we know that and folks that have palliative care programs across the country, community-based, not usually their palliative care program is aside from it's a separate service line from their traditional Medicare home health benefit or service line because of the eligibility requirements. And what happens is patients who are, chronically ill, long-term ill, seriously ill, are on service under the Medicare benefit, home health. And then when they no longer meet eligibility criteria, if they're not homebound, they stabilize, they're not, skilled, medically necessary or part-time intermittent skilled, then the home health agency has no option under the Medicare benefit but to discharge the patient from home health. And many times that's where a palliative care program will pick up, not necessarily having a payer source, unless they're, billing Part B with nurse practitioners or whatever. But, and we don't get into that component, but they do that to sort of keep patients on the radar, if you will, until such time they either come back to home health or they end up, to your point, becoming eligible and choosing hospice. So, and also...
I'm still seeing that as a gap. It's a gap of care.
Yeah. And the other thing, and I'll say this because I've been in home health and hospice both for almost 40 years. And, home health nurses are wonderful. I can say that. Hospice nurses are also wonderful and have a special, more often than not, a very special training and expertise in palliative care, and care and palliation and management of symptoms. I'm not saying that home health nurses cannot or home health clinicians cannot, but it really is, again, just like I agree, CMS is not looking at a carve out, but yet it's still a specialty. It is a specialty unto itself, to be able to take care of these patients.
It really is. So this is where I get on the soapbox just for one moment. CMS is asking for feedback, and everyone out there who's listening, who is having reservations, or even if you support it, but you have some challenges that you would like them to address, this is your opportunity to respond to CMS, to map out what you think, map out any challenges, provide that feedback, because you only get so many opportunities in a year to tell CMS what you think, right? And this is a prime opportunity to do that. So I'm really asking everyone who's listening to this podcast, if you have a foot in the palliative care space in what you're doing right now, please, please, please read the detail in that proposed rule about dovetailing community-based palliative care into the home health benefit. And please, please, please provide your comments and feedback. It's really important.
Absolutely. I agree. And I would say, to consider, what should additional, thoughts for providers to consider right now. Really, we always say, read the rule, look at your own operations and programs to see how the proposed rule provisions will impact these areas. But in this case, this year, it's more than just looking at, most people look at the dollars, right? The payment impact.
Absolutely.
And then if there's a major, change in, a regulation or, standards, but, or quality, anything that would impact them operationally. This year, there are just more, these are serious proposals when we're looking at both the program integrity components and certainly as well as, palliative care. And they both have the ability to significantly impact the landscape and the future of home health.
They really do. And, just a couple thoughts attached to that palliative care RFI. Things like suggesting the formation of a technical expert panel or a TEP might be a good suggestion, or even suggesting, can we do a trial run to even see how this would work rather than jumping in 2 feet with an implementation date. So just a couple ideas off the top of my head for consideration. And I'm saying for the folks who will reply, because we want you to reply, particularly to this RFI. And there are a few other ones in there. Take the time to read through the rule and make your responses and write a letter. And right at the beginning of the rule, it tells you how to go ahead and file your comments. So, Kim, we have our listeners out here. So what should they be doing right now?
Well, again, I think exactly what we said, making sure that they really are taking the time to read this proposed rule and beyond just the words, if you will, the real implication, the potential implication for the industry, but really for each provider, individually as well, beyond the payment impact. I also think that it's important to read in any information that you have. So, for example, you, Jennifer, have done a beautiful job with a proposed rule summary, as you do with all of the CMS notifications. So, thank you. And whatever we can read from the industry, and again, just listening in. I know we are. We did the webinar on August 5th, right?
We did.
So that was, if people haven't listened in to that, that's, again, a more in-depth overview than what we're talking about today. But I think that reading and submitting comments, whether it's, as you said, whether it's directly to CMS or through a state or national association, your voice matters. And if comments are not received on a particular topic, CMS will move forward with consideration, even without those comments. So, although we do expect people to respond, everybody needs to do their part.
Absolutely. And I couldn't agree with you more. Listen to our on-demand webinar. We do include a more detailed information in that, and then our summary also has that information. So thanks for suggesting, Kim, that folks go there and take a look at that as well. So in terms of wrapping it up, we always want to thank you out there for taking time out of your day to plug into our podcast. From Kim, me, and the entire CHAP staff, stay informed and compliant, stay safe and well, and thanks for all you do.